The objectives of this presentation are to understand the definition, etiology, and presentation for high-grade spondies. The presentation will share nuances in surgical decision-making for high-grade spondies and outline options for surgical approaches and management. A high-grade spondee is conventionally described as a myridine grade 3 or 4 slip, which represents anywhere from greater than 50% slippage of one vertebral body on another and up to 100% slip, which then becomes a spondylolisthesis. In some ways, this scoring system is made obsolete by the fact that the deformity is so apparent on standing upright x-rays. But it is also challenging to measure at L5-S1, the most frequent level of slippage. The actual myridine measurement value may not be quite as accurate given the frequent presence of sacral doming on S1, which prohibits accurate quantification of the slip due to a poorly defined S1 end plate. More than the myridine scale, the Boxall or lumbosacral kyphosis angle is more closely a morphologic prognostic factor. In the pediatric and adolescent literature, the normal lumbosacral angle measures between 90 to 110 degrees. The majority of these measurements are able to be evaluated on standing x-rays. However, CT may be useful to assess the degree of sacral doming that may also be present. The sacral dome parameter has sometimes been described in terms of the dome index, which is a non-quantitative measure of S1 cranial end plate dystrophy. The measure ranges from type 0 with no convexity to type 1, which is moderate and centered convexities, to type 2, which describes a high and anterior convexity. Characteristic findings in high-grade spondies also include S1 dystrophy, which is quantified by the S1 index. The S1 index is the length of the cranial end plate of S1 in the sagittal plane, divided by the length of the caudal end plate of S1. A high index indicates better anterior development of the cranial end plate of S1. The smaller the S1 index, the more severe the grade of slip and also the smaller the lumbosacral angle. Clinical presentation of a high-grade spondee varies and is likely dependent on numerous factors, including age, etiology, and rate of progression of the spondee, if at all. Complaints vary from significant motor function symptoms in the form of stress urinary incontinence from sphincteral dysfunction, to hamstring contractures, to cosmetic concerns. Physical findings may also vary depending on frame and size of the patient, but the clinician may observe spinous process step-offs, EHL weakness, paraspinal muscle tenderness, hamstring stiffness, and sacral retroversion. While there are strong arguments that low-grade spondies can be monitored with serial imaging, high-grade spondies often require surgical intervention due to a risk of progression of the slip. Evidence-based risk factors for slip progression include a high-grade spondee found prior to a child's growth spurt, high grades of dysplasia, including sacral doming and dysplastic L5 vertebral bodies, and a lumbosacral kyphosis angle less than 90 degrees. There is some belief that adults typically are at a more stable position and fixed deformity, with less likelihood of progression of a slip when compared to the pediatric population. But given the low incidence of this pathology and the relative divide between the pediatric and adult populations in research, this has not been strongly corroborated with long-term comparison data. Surgical indications for intervening in a high-grade spondee include the risk of slip progression, sagittal balance and spinopelvic parameters of the patient, the presence of radicular symptoms that are attributable to that level, and pain that is refractory to conservative management. Surgical approaches are generally divided into two camps: in situ fusion versus fusion and deformity correction. Arguments for reduction of deformity include a small amount of literature reporting long-term improved self-image outcomes in the pediatric and adolescent population. Other arguments include a reduced risk of pseudoarthrosis, as reduction helps to convert shear forces to compressive forces. Historically, reduction of a high-grade spondee has demonstrated higher complication rates compared to in situ fusion and is associated with longer operative times, higher blood loss, and higher risk of neurologic deficit. As reduction techniques have improved, however, there is an argument that reduction can now be achieved with less morbidity than previously. Modified gains procedures, sacral dome drilling, and other more powerful reduction techniques and tools may be associated with less operative morbidities and high success rates. Literature still has to corroborate these claims to strengthen the argument for reduction. Furthermore, there may be a third option, which is partial reduction and fusion, Anecdotally, the L5 nerve root injuries that are complications in high-grade spondy reductions occurred during the second half of reduction. So achieving even a partial reduction without the complete reduction may arguably provide more benefit with less risk of nerve injury than in situ fusions. The pediatric and adult populations have different etiologies for their high-grade spondies and should be managed distinctly. Younger patients without neurologic deficits may find relief even with just an in situ fusion. Young patients do demonstrate a higher risk of progression due to the mobility of their deformity, growth spurts, and their life expectancy after surgery. Adult symptomatology stems more frequently from degenerative changes and foraminal stenosis from facet arthropathy. Thus, they may require direct decompression during the procedure. Reduction of a high-grade spondy in adults may be more challenging due to increased rigidity of the deformity and stiffness across the lumbosacral junction. These are some surgical pearls that may prove helpful during both the planning and intraoperative phase of surgery. Even a partial reduction will offer significant biomechanical advantages to help in transitioning the affected level from a shear force state to a compressive force state. Given that the highest risk of a L5 nerve root injury will come during the last half of a full reduction, changing surgical aims from a full reduction to a partial reduction may still help with achieving a biomechanically advantageous state while also avoiding the risk of a nerve root injury. Attention to dysmorphic elements in the spine, including a fibrous pars and a sacral dome, are necessary in order to achieve neural decompression with judicious distractive reduction. The authors recommend direct visualization of neural elements in order to avoid iatrogenic neural injury during reduction maneuvers. The use of an inner body fusion, either anterior or posteriorly, may improve the rates of a successful fusion. Fixation with iliac screws may help to reduce the shear forces acting at the lumbosacral junction. Extension of the fusion to L4 may be beneficial to increase surface area for fusion mass. It should also be more strongly considered in the setting of a degenerative high-grade spondy, in which the L4-5 level may also be contributing to radicular or stenotic symptoms in the patient. This concludes our presentation of diagnostic and management considerations for both the adult and pediatric high-grade spondy population. Thank you.